Physical examination shows 3-degree Ligament and 3-degree pivot shift. Intra-articular, it is possible to see a complete tear on the anterior cruciate ligament. The notch is braided with a small shaver in order to prepare the over-the-top passage. An oblique incision is performed at the level of the pes anserinus. After splitting the sartorius fascia, both the gracilis and semitendinosus tendon are harvested gently in order to maintain the tibial insertion. All the adhesion and expansion to the gastrocnemius are divided in order to maximize the length of the grafts, which are harvested with an open tendon stripper. It is important to maintain the graft as long as possible in order to perform the intra-articular reconstruction and lateral tenodesis. The graft is cleaned from the remaining muscle fibers and is whip-stitched with the number 2 non-absorbable suture using a Krakow fashion suture. A spinal needle is inserted medial to the patellar tendon and as distal as possible at the level of the joint line. The needle is inserted through the stump and a small shaver is used to create a hole in the stump and prepare the graft passage. The spinal needle is removed and a small arthrotomy is performed. Then a curved Kelly clamp is inserted in the arthrotomy and is passed inside the tibial stump. The landmarks for the over-the-top incision are the lateral epicondyle, the fibular head, and the posterior border of the IT band. A skin incision is performed proximal to the IT band, and the posterior third of the IT band is open, and the electrocautery is used to open the intermuscular septum. A curved Kelly clamp is inserted inside the anteromedial portal and is pushed in the posterior capsule to create a passage from the interarticular portion to the extraarticular portion. An unabsorbable passing suture is loaded on the tip of the Kelly clamp, which is retrieved outside from the anteromedial portal. The Kelly clamp is then inserted through the arthrotomy and through the tibial stump in order to retrieve the suture from the arthrotomy. Finally, the suture is slid subcutaneously from the arthrotomy to the incision of the graft harvesting. The suture is moved back and forth in order to break any adhesion within its course. The graft is loaded on the passing suture, and by pulling the suture from the lateral incision, the graft is passed intra-articularly. With the camera, it is possible to control the graft passage and its positioning. The proper graft positioning and tension is checked with the probe. A 1.5 incision is performed at the level of Gerdy's tubercle. A Kelly clamp is inserted beneath the IT band and is used to retrieve the remnant portion of the graft to perform the lateral tenodesis. With the knee at 70 degrees of flexion and neutral rotation, 3 stitches with number 2 non-absorbable sutures are used to fix the graft below the femoral physis. After checking the proper tension, other 2 stitches are used to fix the lateral tenodesis at the level of the periosteum in the Gerdy's tubercle. The IT band is closed and the remnant of the graft is cut. Full extension is checked and the Ligament and pivot shift tests are performed in order to control the postoperative laxity. A range of motion exercises are started in the first postoperative days, and the full extension and full flexion are recovered within 6 weeks. At 4 postoperative months, the Ligament test and the pivot shift test are negative, confirming the good result of the technique.